Hi, everyone. Welcome to our webinar. My name is Tian Jiang, and I am a dentist and a faculty at the Harvard School of Dental Medicine, and also a co-investigator at the Center for Integration of Primary Care and Oral Health. I will be your moderator today. We are starting the first of a four-part series through CIPCOH, Center for Integration of Primary Care and Oral Health. And today we are honored to have a fantastic panelist, group of panelists to talk to us about a very important topic. First, I'd like to go through a few housekeeping items. We are fortunate to have about 200 participants today, and we will try to engage with you all and the panelists to make this a little bit more interactive. So we will have some polls to learn a little bit more about you, and then we can learn a little bit about our panelists as well. And our format will be about 40 to 45 minutes of discussion with our panelists, and then we will move to about 15 minutes of Q&A. So if you have any questions as we go along, please enter them into the Q&A box at the bottom, and my colleague Tiff Sarkisian will be collecting those, and we will be discussing those at the end of the webinar. And lastly, we are recording this, so please be on the lookout for the recording in a couple weeks on our website, CIPCOH's website. At the end of the presentation, I will include the website. Great, so I would like to just introduce a little bit about CIPCOH. So let me go back to my slides here. So today our presentation is Stepping Out of Our Lanes and Reimagining Interprofessional Education. So SITCO, as I mentioned, is the Center for Integration of Primary Care and Oral Health. We are a multi-institutional and multidisciplinary center. It's a partnership between the Harvard School of Dental Medicine, the Massachusetts College of Pharmacy and Health Sciences University, the University of Massachusetts Medical School, and Harvard Medical School, along with some great individual collaborators. And at the end, I'll include the names of all of our team members. We are supported by the Health Resources and Services Administration, otherwise known as HRSA, in a cooperative agreement. It is through the academic unit's Primary Care Training Enhancement Program. There are 6 total academic units, or otherwise known as AUs, and on our website, you can see the links to the other academic units. So we are a national resource for systems level research on oral health integration into primary care training, with an emphasis on training enhancements. And so we want to train primary care providers to, 1, deliver high quality, cost-effective, patient-centered care that promotes oral health, address oral health disparities, and meet the unique needs of all communities. So with that, I'd like to start with our first set of poll questions. Tiff, if you could launch that for us, we'll learn a little bit about you, our audience. So if you can complete these 3 questions for us, that would be great, so we can learn about you, and we'll share all the results to the whole group. A little bit of time to get more of our group on here, and then we'll share the results. All right, let's take a look. Great. So looks like primary role, majority is educator, but we've got a great mix of clinicians, researchers, and administration. And this is fantastic. About 60% are participating in interprofessional education and practice. And wow, look at this. This is fantastic. We have a lot of people from all over. This is really exciting. And so this is helpful for all of us to know where you all are coming from. So thank you again for joining us today for this webinar. So we can go ahead and close that. Fantastic. So now I'd like to introduce our panelists. First is Dr. Candace Chen. She is a physician and chair of board of directors at Beyond Flexner Alliance. She's also associate professor of the Milken Institute School of Public Health at George Washington University. Thank you, Dr. Chen, for being here today. Next, we have Dr. Sheree Farmer-Dixon. She is a dentist. She is the dean and professor at the Meharry Medical College School of Dentistry. Thank you, Dr. Farmer-Dixon, for being here today. And our third panelist is Dr. Stephen Purcell. He is a physician. He is an associate professor of medicine in the Division of General Internal Medicine and Geriatrics. He is the director of the Center for Primary Care and Innovation, the Institute of Public Health and Medicine, at the Feinberg School of Medicine at Northwestern University. And he is the medical director of quality, the Northwestern Medical Group, Northwestern Medicine. Thank you, Dr. Purcell, for being here today.
Thanks.
So today's topic, in today's age, in light of COVID-19 and the death of individuals like George Floyd, the realities of the social, economic, and health inequities and injustice are really highlighted. They were already persistent prior to the pandemic, but really are really highlighted today. And so as we as a community reflect, rebuild, and reform our healthcare systems, it's important for us to think about innovation and improvements in our training programs to address the inequity and gaps in care. We, as educators, should think about how we are training the next generation of healthcare providers to better serve their patients and their communities through interprofessional education and practice, otherwise known as IPE and IPP. So in 2019, let me just show you right here. In 2019, Dr. Stanley Goldfarb wrote an article in the Wall Street Journal. He was a professor at a medical school. It's entitled, "Take Two Aspirin and Call Me by My Pronouns." At, quote, woke medical schools, curricula are increasingly focused on social justice rather than treating illness. And I'm going to pull out two quotes here and discuss them with our panelists, but this created quite the controversy when it came out, and I think it's very pertinent today as well. So one quote is, the American College of Physicians says, its mission is to promote the quality and effectiveness of healthcare, but it stepped out of its lane recently with sweeping statements on gun control. Why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? So I'd like to go to our panelists here and start with Dr. Purcell. So why are health professions educators including concepts of social justice and social policy in their curricula when the purpose is to cure patients?
Yeah, thank you. I think that this essay misses the point on several levels. First of all, I think health professions education, medical schools, dental schools, and others are preparing leaders whose goal isn't just to cure disease simply, but it's actually to improve health. And to improve health, requires real fundamental understanding of root causes of health. And just like a cardiologist, for example, who would understand how to treat an acute myocardial infarction, actually has to understand the causes of coronary heart disease, like hypertension and smoking. But if they take it, they also have to understand how those causes can have a huge amount of social determinants and our policy and our policy relevant questions as well. So to change the health of the population, you would actually have to know enough about what causes health and ill health in our society to say, well, where are we going to actually lead the changes that are going to promote health in our populations? And then even for our individual patients, if we don't understand issues around social justice and policies that shape the distribution of healthcare delivery and its quality, you won't understand things like why a patient may not be able to afford medications after that heart attack, why they may not have transportation to complete cardiac rehab after that heart attack. And you also, if you take it one step further back, you would address the questions of why some neighborhoods or cities have access to a hospital that can deliver one kind of care versus another. So if you don't understand the determinants of health on all those levels, I don't think you're really well prepared to go forward as a leader in improving health. And that's really ultimately the job of the health professions. And I think I'll make one other point around this is that to set a dichotomy between social policy, social determinants of health, and biology and basic needs is really artificial, because we actually are increasingly becoming aware of how things like early childhood adverse experiences, when repeated, have biological effects. And they have mechanisms that are neuroendocrine and others that can change the health trajectories of individuals for their whole lifetime. So there's a lot of false distinctions in that essay. But I think to really be well equipped to tackle the health problems that our populations face, we have to start with a broad understanding in health professions education.
Absolutely. Thank you for that. And Dr. Farmer-Dixon, are we stepping too far out of our lanes?
I think as healthcare professionals and educators, no, I don't think that we're stepping out of our lane. I think that it's important for the students that we are training, or the healthcare professionals that we are training, to not only know how to treat the disease, but it's also important for them to know what are some of the causative agents that may be related to that. And that may go back to, as was mentioned, the environment that they're coming from. The social determinants of health play a critical role. And so we are really doing a disservice as educators if when we are designing our curriculum, we're not expanding it. The world has expanded it, and when we're talking about healthcare and health education, we have to talk about optimal health. And if we're going to achieve optimal health, that goes beyond looking at just systemic disease. That also includes understanding the oral health or the oral disease and the impact that it may have on the systemic disease, because there have been any number of studies now that have validated the relation between what is going on in the oral cavity and the impact that it can have on systemic diseases. And then understanding the behavioral health, understanding cultural competency and how that impacts. To give an example, as was just stated, you can prescribe a medication, but if the patient can't afford that, or if based upon their cultural beliefs, they don't believe in that, then you have not treated the whole patient, and you're not achieving the goal of optimal health. So if we're going to talk about improving health and educating the next generation of healthcare professionals, we have to be willing to step out of our lane and move away from the traditional educational model that in some ways kept us in silos and was not involving and engaging in a professional education. So as a dentist, I was not in collaboration, was not trained to be in collaboration with the physicians, or the physicians were not trained to be in collaboration with me as a dentist. and other healthcare professionals. So we have to change the paradigm shift and really move to an interprofessional educational training model so that we have all of the healthcare professionals working together as a team to really promote and drive that goal of optimal health.
Thank you. Yeah, I think this article really touches upon how healthcare delivery and training needs to be dynamic and changing with time so that we are addressing the patients and the population needs. Dr. Chen, could you share a little bit about your work on social mission in medical schools and how that relates to this article?
I can definitely do that. But can I make a kind of a follow-up comment to, I think, Dr. Farmer-Dixon's comments? And this idea, if you'll let me talk a little bit about staying in our lanes, right? Which is very much a keep your head down and do your work kind of a perspective, right? And I think that this idea, this dichotomy of it's either or is also a poor dichotomy, right? As Dr. Purcell was kind of pointing out, right? It's not, yes, we need to be clinically sound, but we can be clinically sound while also addressing social determinants of health and understanding social justice and understanding, you know, the structural issues and engaging in those issues. And I think I want to push a little bit farther to say, you know, this keep your head down perspective, do your job perspective is harmful to our students, to our healthcare providers, and you know, with the dentistry viewpoint, there was a young man named Diamante Driver in the DC area who died, and it's been a couple of years now. He made the national news. He had a tooth abscess, and because of insurance complications, he wasn't able to access care. He ultimately died as a result of that tooth abscess going to causing a meningitis affecting his brain. And you think about the providers who take care of him, right? And if you keep your head down, yes, you take care of him, you admit him to the emergency room, you admit him to the ICU, and you watch him die. And how many times do you have to do that before you just can't do that anymore, right? And so you imagine if people are empowered to lift their head up and to take a look around and to say, why did that happen to that young man, right? And how do we engage and how do we change that, right? To keep your head down is likely leading to issues of moral injury and burnout. Moral injury, practicing in environments and in systems that are unjust, right? And the ability to be empowered to lift our heads up and to say, how do we engage in this? What's our responsibility to engage in this, right? I think is a really, you know, it always just strikes me how much potential damage that we're doing to our students who come in wanting to make a difference. And medical school, we've shown that at the beginning of medical school, at the end of medical school, they're losing empathy, right? We're potentially harming our students. And I think that this idea of engaging in social justice, social determinants of health, being empowered to advocate, partner, and partner in an interprofessional way is a really important, will be a really important strategy for addressing that burnout. Not the only strategy, but really important part of that. So do you still want me to talk a little bit about Beyond Flexner?
Please do.
Okay. So I work with the Beyond Flexner Alliance, and Beyond Flexner Alliance is focused on advancing social mission in health professions education. And what we look at as social mission is everything that a health professions education program, a school, does in terms of advancing health equity. And that is what we train our students in, what we support our faculty in doing, what our leadership is doing inside of the training programs, as well as because most of our training programs deliver service as well as that and engage with communities. And a lot of this work started with some work that we did specifically looking at medical schools and their social mission outcomes. We published this paper in 2010 that looked at medical school by medical school, how much primary care are they putting out? Primary care is seen as a high need specialty. How much are they putting out people who serve in underserved communities? What does the diversity look like? And that was kind of some of the initial, almost the birth of the Beyond Flexner Alliance. And over the last 10 years, I think that we've really evolved as these topics have evolved. It's not just diversity, it's diversity and inclusion. It's the experience of students as they move through and how are they supported and how are they raised into faculty and leadership positions, and how does that then feed back to the rest of, to the pipeline and to diversity. It is about, for example, it is about equity for our health workers. One of the issues that we were going to put in front of our Beyond Flexner Alliance at our conference last year, and it's been postponed to next year, was the issue of medical assistants and kind of predatory training programs for medical assistants, putting people in debt who are then going to go work in minimum wage jobs, right? And what is our seeing what it is inside of our institutions, and then taking responsibility for those kinds of things. So it's really evolved to be more than just this issue of how much into primary care, how much into underserved areas. While those are really important issues still, what does diversity look like? But it is health equity in a much broader view that Beyond Flexner Alliance engages in these days. I think it's really a reflection of the evolution of these ideas in the community.
Great, thank you, Dr. Chen. So social determinants of health, as we've discussed, are an important example of the common theme that ties all of our professions together. Not only all of us here at on the panel, but in multiple other professions as well. So it really necessitates an IPE and IPP. So thinking about the clinical setting, which we've mentioned a little bit now, some may argue that a medical student completing a caries risk assessment in the mouth, or a dental student taking a sample of blood for an HbA1c, or a nursing student helping a patient ensure access to a food pantry is stepping out of their lane. Dr. Purcell, how would you respond to this?
Yeah, I mean, I think that I agree with the statement that that was just posted, that we can't, if we're thinking about a patient-centered view of healthcare and a person-centered view of healthcare, it's not someone's lane, it's what are the needs of that person? What are the threats to their health? And I think potentially, a narrow fee-for-service reimbursement model has really focused us in these lanes, like which is like a very discipline specific. But I think with a little bit of evolution, we can get to the point where we're looking at solving problems that are actually impacting people's health. And when we think about it from a quality improvement perspective, we are always thinking about what's the opportunity to meet someone's need, and what's the way that I can design the way we deliver healthcare to actually make it easy to meet that need, to make it easy to step out of that lane, so that you can actually identify the undiagnosed, untreated depressive disorder. You can inquire about unmet social needs and actually function in environments that don't risk moral injury by having no capacity to help trainees and practitioners address those needs. I think that the other thing that I think I'll mention, which is absolutely not stepping out of someone's lane, is to have enough perspective to understand and be humble when encountering somebody in practice who's different from you. And I think that's perhaps the thing I'll take issue with the most about the woke medical school, which is that if being woke means that you can actually try to accept the fact that you don't understand everything about every person you encounter, and can be humble and can ask questions and can be open-ended, and then can actually apply the skills that you've tried to achieve in your training to help solve the problems that you identify, that requires a sense of humility and a sense of, it's not always about me being, from my perspective, delivering the care in a discipline. It's about patient-centered, person-centered care.
Absolutely. Yes, and Dr. Farmer-Dixon, I wanted to ask you, so currently health professional curricula is already jam-packed. I mean, whenever, CIPCOH has done surveys on these curricula, and we ask what the barriers to integration are, and almost always lack of time and competing priorities. Additionally, it takes a lot of time and resources to do IPE. When you start to move a lot of different groups of people into one space, it logistically is very challenging. And today, with the pandemic, clinical care is on another level of challenges. So, what are your recommendations, or what are you doing at Meharry and in addressing those barriers? Are you muted, Dr. Farmer-Dixon?
Okay. You mentioned the pandemic, and I think the pandemic has driven all of us to look at how we are delivering training and have a different way of thinking. That I don't know, had it not been for the pandemic, we may have moved in that direction, but I don't know that we would have moved as fast as we have. And for example, at Meharry in Nashville, the city has contracted with us. And initially, when the pandemic started and there was testing going on, there were 3 sites that were established, and Meharry was one of those testing sites because we thought it was important, and the city thought it was important, for we are embedded in the African American community in Nashville, and so making certain that all of the communities would have access. So the 3 sites were strategically placed throughout the city. As it has progressed, Meharry is now leading and managing all 3 of the sites. And now you look at this, and this is this coronavirus, you would think this is a medical issue and this is totally being operated by medical. Well, the overall oversight of this is being led by dentists. I am the lead person that is helping with the logistics. The person who's leading logistics is also a dentist. And I think that the operations that we have are really an example of interprofessional collaboration and education at its best. You have the dentists, you have the physicians, you have we have nurses from the community, from Meharry, we have nursing students from our neighboring schools. We have medical students, dental students, our graduate students. We even have social work students from the area. But when you look at the team, it is truly at each one of the sites, it is an interprofessional team that is carrying out the operations of the day-to-day, assessing. You have public health students and public health experts that are at the table, so that we're not just focusing on making sure that people are getting tested, but making certain that we understand the communities that they're coming from. And we know that there's some people that are not being tested, and trying to reach out to them and understand why. We have done partnerships with churches, so that in addition to the 3 sites that we have, we are also doing mobilize. We have a mobilization team that partners with the churches, because in most of the communities, especially in the African American community, the churches that are in those communities, the communities trust them because they are intimately engaged in those communities. And so we have been able to partner with those churches and have additional testing sites, because the philosophy is to meet the people where they are. And even though we have 3 sites throughout the city, not everyone still has access and the availability and the ease of ability to get to those sites. So being able to go into some of those intimate areas and provide services, but it gives the opportunities for the students to collaborate and work together. So as we're talking about how do we train the next generation, this is a true example of when they're there, it's not just about taking the demographic information, understanding, it's a teaching opportunity as well, so that they understand the population that is coming to be tested. They understand what some of those symptoms are and looking for characteristics. And so that goes across all of the professions, and understanding the whole person, and understanding why they're there, seeing the characteristics. And probably one of the most rewarding things was having a first-year student there, and after being there for several weeks, they were able to say, I can see, they were seeing some of the trends that went across when you hear on the news that African Americans that have heart disease, diabetes, they're most susceptible to those diseases, and seeing those individuals coming in and seeing the certain age groups. And it was an aha moment that the student was able to say, I'm seeing some of the things that I have heard about on the news, or for a fourth-year medical student to be able to really bring into full circle all of the different trainings that they've received, and being able to it really helps also for people to be able to appreciate the expertise of everyone that is there and the value that they bring. And when you value and embrace everyone that's that's there, then it tends to lend towards a more effective and a more efficient collaboration. And so I think this pandemic, for us at Meharry, it's really allowed us to move beyond what we were already doing, because we have a patient-centered medical home. We have the Center for Medical Education and Development and Research that really pushes interprofessional collaboration. And so there are already projects that deal with interprofessional education across medicine, dentistry, graduate school, even with some of our neighboring schools that to include nursing, social work. And so this pandemic has really driven us to move in a different direction, and to really think, a lot of times we think when we're teaching that it all has to be done in person. And so quite naturally, of course, when you're talking about dentistry and cutting a cavity prep, or there's some things that have to be done hands-on in a laboratory in the clinic. But I think it has also driven us to see that not every lecture has to be face-to-face. And we can, I think we've all been Zoomed out, WebEx, all of the different educational mechanisms that allow us to be able to teach and train. And so I think as we look to the future in education, we will see that there will be more integrated teaching that will be web-based, that will become a part of the new normal. But I think it also lends to the opportunity for institutions to have greater collaboration. And when we talk about interprofessional and the heavily condensed curriculum, why can't there be a joint course that is taught by all of the faculty from or faculty from each of the disciplines that can be done? And so why couldn't there be a Harvard and Meharry course that is done and it brings the experts from both? But the win is that you have interprofessional collaboration, and you don't have to be physically in the classroom to provide the education and training to the students, and they're receiving it from the experts in those fields. And those are not just limited to any one institution, but this is an opportunity for us to really broaden how we are teaching and training the next generation of healthcare professionals.
Thank you, Dr. Farmer-Dix. There's so many things in there that I love that you talked about. The part that you mentioned about that first year student, that's the perfect example, because we, in theory, interprofessional education and integration sounds fantastic on paper, right? But the whole point is to ensure that these students go out and actually practice the things that we've learned. Sometimes there's some systemic barriers to that, where the culture and practices is very different from what they're learning in school, but it starts from educating them during their training and building from there. And I really love the part where you spoke about bringing the experts together, because the whole concept of staying in your lane kind of is holding on to what we think are the barriers to our profession. And really integration fills those gaps in healthcare, because we are able to say and be modest and say, you know what, I'm not an expert at this. I know someone at Meharry is phenomenal in this area. Let me collaborate and improve the health of the patient. So thank you for those comments. I really appreciate them, and it's fantastic what Meharry is doing. Dr. Chen, I wanted to ask if you have any examples of programs where you're teaching or others where you've seen some areas of innovation in the space of IP or IPP.
Yeah, I think that there is I'm not going to say a lot of innovation. I'm going to say there is a good amount of innovation. There could be a lot more to the point where it's no longer considered innovative anymore, I think is ultimately the goal. What I thought I'd talk about is one of the things that Beyond Flexner Alliance does is it recognizes social mission innovators effectively. We have something called the Macy. It's funded by the Macy Foundation. The Macy Foundation awards in social mission. We recognize a number of different kind of categories. And one of the winners which would have been awarded at our last conference and will be awarded at our next conference is Florida International University's Neighborhood Help Program, which is a longitudinal interprofessional experience. And when I say interprofessional, they include the medical students, the nursing students, physician assistant students, but they also include social work students as well as education students and law students. And it's a longitudinal experience over the course of their education where they actually, and I'm not sure what this looks like right now, but they go and go to families' homes and work with families through the course of their education. So the experience itself is interprofessional. It is truly a going to the family. And then even in the doing, they then partner across sectors. For example, they actually partner with the police, which is obviously a very sensitive area right now, and an area that needs a lot of reform as well. And so this is it's an example of truly interprofessional, and I like to say interprofessional plus, right? It's beyond the health professions, and recognizing the expertise, I think, as Dr. Farmer-Dixon was kind of saying, we're not proposing to turn medical students and future physicians into social workers. There are social workers, or into lawyers, right? Like there is expertise out there. The whole beauty of the interprofessional education and practice is to come at it with humility and recognize the strengths and the value that each member of the team brings. And for these really difficult issues of social determinants of health, social justice, right? Like you really need that interprofessional team, that interprofessional plus team, right? To be able to start to engage with those things. And as health professionals, we come to it with humility, but we come to it also bringing our power, right? As a physician, as a dentist, as a nurse, right? We hold a certain place in society that gives us some power. And so there's the question of what do we bring? And we bring our power, we bring our willingness to engage, we bring, our expertise from what we do, our insight, and we bring that to the team. Not that we need to lead the team or lead the effort. So that is, FIU program has been there. It is, and they've published on it. They have a wonderful site that can give you more information on what it is that they do. But it is it's a core investment and a core curricular component, right? That other programs could adopt or adapt. Another awardee is, and this one is also very interesting. We have a brand new Rising Star Award. So we recognize that a lot of initiatives are being led by earlier career people. And our Rising Star Award is going to Dr. Robert Rock, who right now is a family medicine resident at Montefiore. But when he was a medical student at Yale, he and a colleague started a health justice elective. And the health justice elective is a interprofessional elective at this point that takes, and it's an elective, it's not a requirement. And so it takes a group of students through a series of seminars that are all about health justice issues, and as well as exposing them to the idea of being advocates for those various topics. Things ranging from well, implicit bias to food security issues, right? And so the kind of interprofessional exposure to different issues and thinking about how you would advocate to change those things in your communities, right? Empowering people to be able to engage in those things. There are, and those are just two examples. One of the things from working with Beyond Flexner Alliance that we realize is that there are people and there are people and groups and institutions who are engaged in this work. It's not often, it's not often recognized. It's not well funded, but that is, the earlier question of that challenge that we have of our curriculums are so full, what do we do, right? As terrible as it is, one of the things I always like to recognize is kind of as I was just saying, there are many people who are working in these areas and they've been working in them and they've been pushing against all the disincentives to do this kind of work for a very long time. And as much as I hate to say that there is an opportunity right now, because the opportunity is being created by COVID-19 and the George Floyd and the kind of and the demonstrations, the terrible demonstrations, not that the demonstrations are terrible, but what's happening with the demonstrations, are raising the visibility and raising the clarity on health disparities being driven by social determinants, right? On who are our essential workers, right? Why are they at more risk? What is their access to safe housing? What is their access, what is your ability to quarantine and stay at home? All those kinds of things that are much more driven not by your health status, but by your social determinants, right? And these things are coming up and it's giving us the opportunity to say what really matters. What really matters? Because sometimes we do have to shed certain things to be able to advance other things, right? And if we can really push on this idea right now of what really matters, then we might move a couple more organizations towards the FIUs and towards, well, again, the health justice elective. And again, I hate to say it, it's an opportunity, but we have an opportunity right now. We shouldn't lose it. We don't want to go back to the status quo, right? We need to move forward from here.
Thank you, Dr. Shen. Yeah, I totally agree. I'd like our audience to have a moment to say something, and we'll launch our next poll, Tiff. And we want to know what your concern in IPE and IPP is. We saw that a good number of you all are participating in interprofessional education and practice. So Tiff, if you could launch that next question. Great. And Tiff, if we could close that out and see our responses. So I talked about time, but here it looks like the most common is that the current healthcare system limits opportunities for integration. Yes, we've seen that in our work at CIPCOH. I see some nodding heads here too. We all agree here. So I want to, this leads very nicely into our kind of wrap up section here of maybe our panelists could also weave this into their kind of final words, but I'd like to ask our panelists for kind of like a 2-minute wish list. It can be a little longer than that, but for the future of IPE and IPP. Think big, like what, if you obviously we can't have all resources, but what do you envision? What are you hoping? What is, like Dr. Chen was talking about, we're going to seize this opportunity. What do you see as your big wish? Why don't we start with Dr. Purcell?
Sure. I mean, I think that this is a catalytic moment. And what I'm wishing for is that we prepare health professions trainees to enter worlds where high functioning teams actually meet the needs of patients to care for them. And I think that when we get very narrowly siloed, we don't learn enough to actually understand, that this person's problem may be best solved by a lawyer or by a social worker or by somebody else. And I don't even know how to communicate effectively with that person or how they do their job. So just like we don't practice every subspecialty, but we gain a familiarity with what the kinds of problems differently trained people can accomplish, I think we need to be preparing people to truly understand the broad array of disciplines that can work together to solve problems. I also really want a workforce that's prepared to think in terms of systems. We are not just solo practitioners out there on our own. We are embedded in complicated organizations, and we can do two things. One is that we can, as the clinicians, we speak with a moral voice of, these are the problems that our patients are facing, and these are the ways that our current system is failing to address them. So there's sort of a moral authority to speak to the need to put interprofessional, interdisciplinary teams into place to actually address the problems that our patients face. And then the other is to actually learn how to work in those teams, to have humility about the things we don't know, and to be able to lead and provide guidance about the things that we do know. I think that a lot of times when you think about teams working together, you can also solve problems more in ways that are actually feasible. So I think one of the best examples I can think of currently underway in primary care is integrated behavioral health in primary care. We have a shortage of psychiatrists. We have a shortage of affordable psychotherapists. But yet, if we take on as a group the responsibility to actually seek out sort of unaddressed mental health concerns and issues, and then figuring out a way we can actually deliver that care, it's like we're not going to do that effectively unless we reinvent the team. And that may involve primary care working together with a licensed clinical social worker or others. So that's kind of what I wish for trainees, is to emerge into the world being ready to participate in systems which are going to solve problems in ways that are actually sustainable, and also to sort of be that moral voice to say, here are some problems in need of a solution.
Dr. Purcell. Dr. Farmer-Dixon?
I think if we're going to talk about interprofessional education, where do we start with that? We start with the training in school. And so if we were to begin that with expecting everyone to appreciate each other's expertise in their discipline, you start with that training in medical school, in dental school, in pharmacy school. And so having a collaborative course, an example of one thing that we've done is there's a case-based interprofessional course that brings a lot of different disciplines together as students. And so if you have a course where there is a case, and so you have social work there, you have the lawyers there, you have political science majors there. You get beyond the traditional scheme of when you're thinking about interprofessional education, because as we've talked about, there are policies that impact the health care that is delivered. And so having law students there, having health policy students that are a part of that, of this integrated course and this integrated training. So it's not just taking a course and providing the didactic knowledge of what value your expertise brings, but actually being engaged in clinical training where all of those aspects and components are together, the behavioral health component. We can't move the pendulum and expect, if they don't have that training when they are in school in that fashion, that once they become healthcare providers, that's going to happen. If we want that to be the ultimate goal at the end, we have to start it and integrate it at the beginning and throughout the educational training. So I think that's the first thing that we have to do. And if we, and the other thing would be, when we talk about healthcare and having a universal health record, so that when you have that health record, when we talk about, change the word from medical record to being a health record. So it doesn't just ask you the medical questions, diabetes, heart disease, and those things, but it can ask you questions. When was your last dental visit? Do your gums bleed when you brush? Are your teeth sensitive to hot and cold? Some basic questions will give insight to what is going on with their oral cavity and the impact that it could have. And having some behavioral health questions, having some diet questions, nutrition questions, so that you have a true comprehensive picture of this patient, and it's truly a health record. And it is a universal record that can be, that follows that patient. You're not having to transfer your records. Every health profession that this person may see would be able to see that record and have a full picture of the person. And that's where we talk about a patient-centered medical home that's putting the patient at the center. And we're making certain that all of the needs of that patient are being met.
Thank you. Dr. Chen?
That, I don't know what I was going to say before, but now I'm going to go with, you know, the language that we use, but also the systems that we have in place that are driven by things like how we pay for healthcare, that are driving us and have historically driven us in directions that are not interprofessional and do not put the patient and their families and their communities at the center of health and healthcare. You know, I think that my wish list is that we take that structural lens, just as Dr. Farmer-Dixon just did with the issue of language and data sharing and information sharing across different professions. And we start to dismantle those structures inside of our own houses, our organizations, our healthcare systems. And when you think about applying this lens of IPE, IP, EP, interprofessional practice and education, one of the first things that we need to address social justice, to address social determinants, one of the first things that we need to do is we need to apply that structural lens to our own organizations, our own systems, and then move to change those things. And I think about that poll that you did and the one that came out first of like our health systems don't support this, right? My wish list is that we take that as a responsibility, and we as educators, because we have a responsibility to our students and to our future healthcare providers, because we have a responsibility to the people and the communities that we take care of. We have a responsibility to our community partners, take our power, well, that we empower ourselves and that we take that power and we aim to change those things. And you know, it's everything from being clear with our organizations and our associations that this is what we want and we expect out of healthcare, health systems, and what they advocate for, and then holding them accountable.
Thank you so much. Yes, I mean, it all connects together, and the tying thread is that if we, as these different professions, can really focus on the patient and the population, and how do we get to the point where we're taking care of them as a whole person. It doesn't have to be one way. There are many different directions. It's multi-pronged in terms of approach. And so we had some fantastic ideas about how to approach that. I love the idea of the health record as opposed to the medical record. And so I want to thank our panelists for just really speaking honestly about this very important topic and sharing what great practices are out there already. I do want to leave you here with our CIPCO's information here. We will be doing another webinar in the fall on integration at the postdoctoral level. Today we focused on pre-doctoral, and we have a lot of team members as part of CIPCOH, so I do want to acknowledge and thank them all. I do love polls, and we've had a fantastic response already today, but I do want to leave you with one more on learning about what type of integration topics you'd like to learn about. And that also helps us find out what's on your minds. So Tiff, if you could launch that last poll for our audience, that would be great. Great. Tiff, would you mind launching the results? So it looks like there's interest all around the board. So highlighting current best practices of integration. I loved hearing those examples today. It sounds like getting more of that out there and sharing those stories of what these innovators are doing. Some toolkits and guidelines on integration. Again, we don't need to reinvent the wheel. It takes a lot of time, a lot of resources. So if they're, CIPCOH's done some work on seeing what the different curricula on integration or oral health integration into primary care, so those can be shared as well. And developing a community of practice or network of individuals and organizations focused on integration. And then, of course, policy considerations regarding integration. It's all part of that multi-pronged approach that we were just discussing. So thank you, everyone. We could probably speak about this for much longer. We've already hit the hour. We weren't even able to approach our Q&A, but I want to thank you all again, Dr. Chen, Dr. Purcell, Dr. Farmer-Dixon, and my team here. We thank you for your contributions and the great work that you're doing currently and moving forward. So thank you so much. Thank you, everyone, and have a good rest of your day.
Thank you.